Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Lieutenant General Dr. Narendra Kotwal. Sir is MBBS, MD, DNB, MNA, MS, MPhil, DM, FRCP, Director of Endocrinology, Department at Paras Health, Panchkula. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is optimal thyroid hormone replacement therapy. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Yeah, thank you, ma'am. Good evening, everyone. Now, as Madam told you, today's topic is optimal thyroid hormone replacement therapy. As all of you will agree with me that despite the agreed tenet of using levothyroxine in the treatment of hypothyroidism, there are certain nuances in achieving actual euthyroidism. So my talk would be basically based upon using levothyroxine in day-to-day management of hypothyroidism, and all of us deal with such patients. So, what are the goals of treatment? The goals of treating hypothyroidism with thyroid hormone replacement remains to provide resolutions of patient's symptoms and hypothyroid signs, along with normalizing the biochemical abnormalities of hypothyroid state and avoiding under or over treatment. And as of now, levothyroxine replacement therapy, levothyroxine is the treatment of choice. The optimization of therapy for all hypothyroid patients remains the goal of all endocrinologists, physicians, everyone. So, where all levothyroxine is used, one is hypothyroidism. It can be used as a specific therapy for thyroid cancers. Earlier, it used to be used for the resolution of the goiter, diffuse goiter, but as of now, we know that is not of much use. Some misuses of levothyroxine therapy, like some people use it for weight loss, some people use it for so-called metabolic insufficiency. Some facts about the levothyroxine. It has a very narrow therapeutic range. Regardless of indication, careful dose titration is necessary to avoid consequences of over or under treatment. Even small changes in dose of levothyroxine can shift a patient from euthyroid to hyperthyroid or hypothyroid state. And it's very important to use same brand. Whichever brand you are using, please continue to use same brand. Levothyroxine has a long half-life, 7 days half-life, and 80% of the absorption of levothyroxine occurs in the jejunum and ileum. That is why dose which we give is 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 20% more than the requirement in the body, because 80% is absorbed. And what is the dose? Dose generally is 1.6 to 1.8 microgram per kg ideal body weight, and 6 weeks are required for equilibration. That is why whenever treatment is started, repeat TSH should be done after minimum after 6 weeks. Levothyroxine replacement in a physiological dosage to optimize TSH may be associated with mildly elevated free T4 and normal free T3. Why it happens, I will discuss subsequently. In some patients, owing to their differing half-lives, intermittent hormone injection may result in normal or in elevated thyroid hormone levels, but fails to normalize TSH. Improper storage leads to reduced potency of levothyroxine. Normally, the bioequivalence remains unchanged over a shelf life of more than 36 months. But exposure to sunlight, high temperatures, humidity, and oxygen significantly accelerates the degradation of levothyroxine tablet. Exposure to direct sunlight for 80 minutes results in more than 60% decomposition of levothyroxine. So it is very important to properly store, keep the levothyroxine tablets away from sunlight. Blister packings may eliminate refractory hypothyroidism due to improper storage. Now, as far as the dose titration is concerned, this was a prospective randomized double-blind trial, 50 patients without cardiac symptoms, randomized to either given high dose, that is 1.6 microgram upfront, or low dose, gradually increased 25 microgram, then every 4 weeks, and levothyroxine given as a liquid at bedtime, and adjustment every 4 weeks. So, what was found that whether we give high dose or subsequent small incremental doses, keep on increasing to the highest dose, Over a period of 20 weeks, levothyroxine concentration remains same, but these are in the patients who do not have underlying cardiac disorders. Patients who have coexisting heart disease, treatment should be initiated with lowest dose, such as 12.5 to 25 microgram daily, and gradually increase in dose based on symptoms and TSH level. Dictum is start low, go slow. May be prudent to initiate therapy with low doses in elderly in general. So requirement of a dose depends on the body weight and on, on the underlying thyroid status. Now, if it is autoimmune thyroid destruction, there may be residual thyroid function. So dose requirement is around 1.62. Post RAI dose is still lower because it takes some time for thyroid follicles to be destroyed. So 1.54. Whereas patients who have got surgical thyroidectomy, their dose requirement is higher as compared to autoimmune hypothyroidism because there is no thyroid gland. So everything has to be given from outside. So it's very important that we always say that levothyroxine should be taken empty stomach early morning with the water. Why? You see our hair, one can see if it is taken with the espresso coffee, the peak T4 is 36, whereas with the water is 54 nanomole. So that is the reason we say that it should be always taken with the water, not with any food stuff or with tea or coffee. Institution of replacement therapy, as I told you, depends upon the degree of hypothyroidism, type of hypothyroidism, age and general health of the patient, weight of the patient, and if rapid institution is required, then if patient doesn't have any cardiac symptoms, one can give upfront higher dose. Lesser dose is required in central hypothyroidism and post-ablution, and higher dose in infants and children. So what are the requirements? Generally, adults with primary hypothyroidism, 1.6 to 1.8 microgram per kg body weight. If we are giving in suppressive doses for like thyroid cancer, 2 to 2.5 microgram per kg body weight. In elderly, 25 to 50 microgram per day. Very elderly, start with 12.5 or 25. Patient with CHD, start with 25 microgram. Start low, go slow should be the dictum. In pregnancy, there is an increased requirement, 30 to 50% increased requirement. Now, why this increased requirement occurs? Because we know that estrogen increases TBG. So more binding of the levothyroxine to TBG, then increased plasma volume. Then because of the placenta type 3 dehydrogenase, there's thyroid hormone metabolism occurs. So 30 to 50% higher requirement of levothyroxine as compared to non-pregnant levels. Hypothyroidism, congenital hypothyroidism, 10 to 50 microgram per kg starting dose. In the first 6 months, 8 to 10. After 6 months, 6 to 12, 6 to 8 microgram per kg body weight. In patients of infantile congenital hypothyroidism, 8 to 10, and juvenile and adult congenital hypothyroidism will be, once they become adult, 1 to 3 microgram per kg body weight. This is a very nice graph to show that what happens to TSH levels if it is taken before breakfast, with breakfast, or at bedtime. So one can see the least variability is when it is taken early morning, empty stomach. That is why dictum is that it should be taken empty stomach in the morning. Once levothyroxine is started, how do we monitor the symptoms? So what are the changes which occurs? First thing that patient may tell that there is an increased urine output, which is because gag which has imbibed water, from that gag that water starts coming out and there is an increased urine output. If serum sodium is low, it becomes normal. Pulse and pulse pressure becomes normal. Appetite improves. Constipation is better. Then psychomotor activity improves. DTR takes their time to improve. Hoarseness of voice and skin hair changes are lost to recover. Increased requirement, as I told you initially, occurs in pregnancy, GIT disorders, various drugs which interfere with levothyroxine absorption, like listerine, sulfate, aluminum hydroxide, antacids, calcium carbonate, iron sulfate. Increased metabolism of levothyroxine by the enzyme induction, like drugs like rifampicin, carbamazepine, estrogen, phenytoin, sertraline, statin. Drugs which block T4 to T3 conversion, like amiodarone, and drugs which block deiodinone synthesis. Decreased dose requirement may occur in persons who are elderly, age more than 70 years. Why? Because there is a decreased plasma volume and lean body mass is less. And if somebody is on androgen therapy, why? Because it decreases thyroxine bonding globally. So free thyroxine is more available. What should be the target of TSH once treatment is started? Pre-conception, lower quartile of reference age, that is less than 1.2. In pregnancy, first trimester, less than 2 to 2.5. Children with congenital hypothyroidism, less than 5. Young patients, 1 to 2.5. Middle age, 1.5 to 3. Elderly patients, less than 65, more than 4.5. As the age increases, TSH has to be kept on the slightly on higher side. In my clinical practice, what I follow is that after 60 years, whatever the age, that should be a TSH. 70 years, 7 TSH, 80 years, 8, 90 years, 9. TSH and FT4. All of us know that there's an analysis of relationship between TSH and FT4 in a population illustrates that rather than being a simple linear relationship, the relationship may in fact be more complex and curvilinear. The slope and relationship appears to be affected by sex, age, genetics, use of levothyroxine, with each individual having TSH FT4 set points that differ from the population as a whole. Every patient has got a different TSH set point. TSH on LT4 treatment. This is interesting data to show that more than 1,62,000 patients with hypothyroidism and their TSH measurements were done over a period of 23 years. The data shows that 11.6% of TSH values were below zero point 0.4 and 32.4 were above 4. That means roughly 43% patient did not have TSH in the normal range. What about doing other biomarkers of euthyroidism regarding sex hormone binding globulin, osteocalcine, cholesterol, creatine kinase, ferritin, antilopeptide, and so many others. Physiological parameters like heart rate, pulse, wave arrival time, echocardiographic parameters of LV function, DTR, and BMR. In clinical practice, biochemical parameters are difficult to follow, but in practice like heart rate and DTR can be done. Levothyroxine in specific situations. Pregnant patient, I told you earlier also, increased requirement. Children, dose requirement to start with on higher side. Non-adherent patient. Sometimes patient comes at TSH is on higher side, but they're non-compliant. So these patients can there be something that adherence can be increased. One is that one-to-one discussion with the patient, and still, if patients are not following, then supervised levothyroxine like weekly doses can be under supervision can be given to this patient. In central hypothyroidism, slightly low doses are required. Older patients and patients with medical condition, dictum, start low, go slow. In hospitalized patients, sometimes levothyroxine is stopped, and it has been seen that patients who are not given levothyroxine while being admitted in the hospital, their hospital stay is prolonged. In coexisting adrenal insufficiency, first steroid replacement and then thyroid hormone replacement. Monitoring. Now, these are the clinical scenario that if one patient comes, TSH is 6.8 and TSH is 10.5. So this is the patient who is non-compliant. He's taking medicine, but sometimes he's missing because T4 is normal and TSH is still not in the normal range. Another patient, T4 is low, TSH low. That means patient either is newly diagnosed hypothyroidism or patient is not taking treatment at all. Third patient, T4 13.8 and TSH is high. This is a patient who is a non-compliant, but prior to treatment, he has started taking treatment. The day he had given his blood sample, he has taken levothyroxine in the morning. TSH is normal and still symptoms persist. So, what are the reasons? One is that autoimmunity rather than the thyroid status itself can cause various symptoms. Symptoms caused by associated conditions or comorbidities, incorrect attribution, and unrealistic expectation. Levothyroxine is the only medication, so hypothyroid symptoms anticipated. Symptoms due to lifestyle issues and normal aging will not be addressed by levothyroxine. Awareness of the chronic condition. Then there are certain subsets of the patient where there may be actual tissue hypothyroidism. Why? Because levothyroxine, actual hormone is T3. Levothyroxine has to be converted by dehydrogenase to T3. There may be a certain conditions because of the polymorphism of the dehydrogenase or the problem in the transporter system, that conversion may not be there. So that actually in the tissue T3 levels may be low. So these are the patients who may have some symptoms, but this subset of patients are minuscule. So if we find in our day-to-day practice patient comes with increased TSH while on levothyroxine, please check compliance. Then look for other causes like GIT disorders, celiac diseases. Then very important, look bioavailability of the drugs, whether brand has been changed or not. It's very kept, as I told you, this is away from the sunlight. All those things have to be looked into. Patients who are normal TSH is normal, but still they complain that they are having problems. So, is there any uh, point in giving T4 T3 combination? As I told you, the some of the patients may be having tissue hyperthyroidism. As per the British Thyroid Association Society, these guidelines came last year. This, as per them, quote, we suggest that for some patients with confirmed hypothyroidism and persistent symptoms who have had adequate treatment with the levothyroxine and in whom other comorbidities have been excluded, a trial of levothyroxine along with levothyroxine combined therapy may be warranted. The decision to start with levothyroxine should be shared decision between patient and clinicians. For individuals on levothyroxine with a normal TSH level, combination therapy can be initiated by decreasing levothyroxine dose by 12 to 25 microgram and adding levothyroxine 2.5 to microgram once or twice daily. For monitoring, there is no consensus as how monitoring should be done, but generally serum T3 should be assessed 2 to 4 hours after levothyroxine consumption. Normalization of serum TSH and optimization of symptoms remain the treatment goals. If no symptomatic improvement is noted, for 6 months, levothyroxine monotherapy can be resumed. Now, this is just to show, I'll come to the last one, how to substitute levothyroxine. Roughly 1:7 of the current LT4 dose. Suppose somebody is taking 100 microgram, 100 divided by 17 comes to around 6, but we take it 5. So 100 microgram, LT3 will be 5, multiply it by 3, 5 into 3, 15. So decrease dose of levothyroxine by 15, that is 85 microgram. If somebody is taking 125 microgram of LT4, we give 7.5 microgram of LT3 and 100 microgram of LT4. If somebody is taking 150 microgram, 10 microgram of LT3, 5 morning, 5 evening, and 125 microgram of LT4. Now, there are some new novel drug relief formulations are being also attempted. We know that liquid levothyroxine is also available. So, no, it is not available as of now in India, but it's available outside. So, novel drug delivery system so that that GIT absorption is enhanced. Now, there are some clinical scenarios. This is a 48 years old lady. She has a weight gain of 6 kg over 4 years. T4 is 9.5 microgram per deciliter and TSH is 6.5. And somebody puts her on levothyroxine 50 microgram. Over a period of next 1 year, she gains 2 kg more and TSH is now 3.1. Now, point here I would like to highlight is that in T4, you see our hair is normal and TSH is marginally increased. In obesity, as such, TSH is slightly on higher side. Why? Because from the adipose tissue, leptin is secreted. Leptin increases TRH, which increases TSH. It is not that TSH is causing weight gain. It is the adiposity which is causing increase in TSH. Regarding subclinical hypothyroidism, a patient comes TSH more than 10 microgram. If TSH is more than 10, if it is less than 10, we do not treat. More than 10, yes, patient may require treatment. Or if there are associated conditions like goiter, family history, antibodies positive, dyslipidemia, infertility, then one may treat subclinical hypothyroidism even if TSH is less than 10. Dosing is roughly 25 to 50 microgram and reduced doses is in elderly and patients with heart diseases. Serum TSH levels to be measured minimum after 6 weeks. As I told you, T4 has a long half-life, 7 days, so 6 half-life after 6 half-lives. Target TSH 0.3 to 3 and annual examination after achieving stable TSH levels and look for the neuropsychiatric effects. Why subclinical hypothyroidism should be treated? Because it occurs in 3 to 20% of the patients. Patients with that from subclinical to hypothyroidism conversion. Patients with goiter and thyroid antibodies at higher risk of progression. Associated risks like progression to overt hypothyroidism, cardiovascular effects, hyperlipidemia, and neuropsychiatric effects. Now, here's a patient whose radioablation has been done for Graves' disease. Now T3 is 92 nanogram per ml. It's normal. T4 is normal, but lower side of normal, and TSH 2.5. This is the patient who is going into hypothyroidism. Why? Because after post ablation, as we know that TSH remains suppressed for a longer duration. So after ablation, immediately you see TSH is in the normal range and TF4 is lower side of normal. So this is the patient who will require levothyroxine. There are clinical scenario we'll find in our day-to-day practice patients who are on the LT4 for unclear reasons. So how to deal with such patients? Like this patient, 32 years male, no family history, no goiter, his euthyroid, previous records are not available. So in such patient, what one can do, decrease the dose by 50% in the dose, repeat TSH after 4 to 6 weeks, and see if TSH is increasing, this patient requires treatment. If TSH is normal, this you can stop levothyroxine and reassess after 6 weeks and look at the TSH. If there a patient is hypothyroid and if patient has to go surgery, should surgery be deferred or surgery can be done? If surgery is emergent surgery is required, close observation for CO2 retention, bleeding, infection, and hyponatremia. These should be catered to, and patient may be subjected to surgery. And look, as such, treatment should be started. In myxedema coma, please, it's a game of all H. Hypothyroid, hypothermia, hyponatremia, hypercarbia, hypocardia, uh, and hypoxia. So we have to take care of all H and thyroid hormone replacement to be started. What about various the thyroid diets and alternative approaches? Patients come to us from the taking notes from the Google about all these things. We have to sit with the patients and tell them, as of now, levothyroxine has to be taken. As far as the dietary supplement is concerned, there is not enough evidence that with dietary supplement one can achieve euthyroidism. So to summarize, hypothyroidism is a common condition requiring lifelong therapy with thyroid hormone replacement. The results of levothyroxine initiation and adjustment are believed to provide patient satisfaction with therapy in majority of cases. Levothyroxine therapy must be continually monitored as dose requirements may change across the lifespan and with changes in a patient's physiological and medical situation. A subset of the patients do not feel well while taking levothyroxine despite the best attempts to optimize therapy. For these dissatisfied patients, if other potential causes of their symptoms have been fully addressed, a trial of personalized combination therapy with the addition of neothyronine can be contemplated and can be continued as long as the patient's benefit and safety maintained. So, thank you everyone for patient hearing. I'd be glad to answer if there are any queries or your comments and your opinions about your treatment of the hypothyroid patients.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to
Yes,
take
yes,
them.
sure.
So, sir, the first question was, what factor determine the appropriate dosage of thyroid hormone replacement therapy for patient with hypothyroidism?
Yeah, I think partly I discovered there are depends upon 3 4 factors. One is the residual thyroid function. If, as I told you, if it's autoimmune thyroid disease, dose requirement may be low. Vis-a-vis somebody who has gone total thyroidectomy, then weight of the patient, weight of the patient, thyroid, and even what is the TSH at that particular time. If it's very high TSH, high dose may be required. And the coexisting condition like patient is having IHD, cardiac diseases. So all these factors have to be taken into consideration. And here again, if it is autoimmune thyroid disease and if it is autoimmune adrenalitis also, first replace steroids and then start thyroxine replacement.
Thank you, sir. There's another question. How do comorbid conditions like cardiovascular disease or osteoporosis influence the choice and monitoring of thyroid hormone therapy?
Great question. Now, for cardiac diseases, as I told you, start low, go slow. Generally start with 12.5 microgram, keep it increasing every week, and try to look at the TSH after 6 weeks. As far as osteoporosis is concerned, if patient is hypothyroid, if you are giving levothyroxine and maintaining TSH within normal range, it will not lead to further bone loss. It is only once TSH is suppressed, it will increase the osteoclastic activity, and that can lead to bone loss.
Thank you, sir. There's one last question. It is, How should thyroid hormone levels be monitored to ensure therapy remains optimal? And what are the recommended interval for testing?
Right, great. As I discussed earlier, also monitoring of primary hypothyroidism is by the TSH. So once treatment has been started, repeat TSH should be done minimum after 6 weeks, but it can be done after 8 weeks also. It is TSH. Whereas if it is a central hypothyroidism, monitoring is by the free T4, and free T4 should be kept on the upper side of normal.
Thank you so much, sir. That's all from our audience. And before concluding, sir, any take home message from your end?
Yeah, take home message is that levothyroxine is the treatment for primary hypothyroidism or central hypothyroidism, and same brand of medicine should be used. Repeat TSH, please do after TSH. Increase the dose in pregnancy, and in elderly, TSH should be kept on the higher side. So, as I told you, if 70 years, TSH 7, 80 years, TSH 8. And if at all, after somebody on hypothyroidism comes with atrial fibrillation, please rule out our treatment. Look at the TSH if it may be suppressed.
Thank you so much, sir, for joining us today. With your permission, sir, I would like to conclude today's session. Thank you.
Thank you. Thank you very much.